This patient has a paralytic brow ptosis from a long-standing partial lower motor neuron 7th nerve palsy. The skin is marked with the patient upright. The lower incision line will form the scar line. It is positioned immediately on or even just within the upper edge of the brow. It does not stray away from the brow, as this may produce a more visible scar. The brow is now lifted to the desired position. The marker pen is suspended in line with the lower incision, and the brow allowed to drop. The marker pen is now sitting at the desired superior edge, and the mark is made. The same technique is used to make several more upper incision skin marks. The line can then be completed. The precise shape, height, and width of the excision must be individualized. For example, in some patients, one might want to extend relatively medially, while in others a smaller temporal brow lift may be adequate. Additionally, the temporal aspect can be brought to a crescent, as you see here, or can remain wider if greater lift is required temporally. The supraorbital notch can also be palpated, and the supraorbital and supratrochlear neurovascular bundles marked. The blade is being used to make a relatively deep incision, although it should be shallower medially in the region of the supraorbital neurovascular bundle. Care is taken with the angle of the blade, which should be perpendicular or even angled slightly away from the brow to minimize brow follicle loss. Excision can be done with a blade, scissors, electrocautery, or monopolar diathermy, as you see here. The latter two may result in less bleeding, although it can still be a relatively hemorrhagic operation, at least for eye surgery. Knowledge of the anatomy of the scalp is important. Common practice is to excise skin and subcutaneous tissue to expose frontalis laterally and centrally, although medially staying within subcutaneous tissue to protect the neurovascular bundle. If the brow ptosis is paralytic, then frontalis may also be excised laterally to expose periosteum. Having said this, there is little evidence on outcomes with different depths of excision. While the tissue is being excised, great care is taken not to inadvertently shelve the inferior edge of the incision under the brow, which would excise hair follicles. Deep sutures are being placed. These serve two purposes. Firstly, although the periosteum is not formally exposed in the present case, the sutures take a bite of periosteum to fixate the brow at the desired position. Secondly, the sutures exit in the dermis as close to the skin edge as possible, carefully bringing together and aligning the skin edges so that there will be minimal tension on the skin suture, which in turn will minimize scarring. Prolene 4O sutures are being used in this video, but an absorbable monofilament suture, such as monocryl, can also be used. Braided sutures such as Vicryl should probably be avoided, as they can slowly extrude postoperatively. The deep sutures are tied on a bow and the brow position checked. It is found to be satisfactory and the sutures are tied off. The skin is carefully closed. This video shows a continuous subcuticular suture, although interrupted or a simple continuous suture may also be used.